And so I want to give you a little bit of background of who I am. I'm one of the medical directors at Karius. I'm trained in pediatric infectious disease. One of the things that led me to this company was actually in my 15 years of practice at Boston Children's Hospital. I developed an expertise in encephalitis, which is brain infection. And it was very frustrating how many patients that came with brain infection that we never could find a cause. So imagine a child totally normal, then comes in devastated, can't even do the basic functions of everyday life, and you have to tell their parents, we have no idea what caused that. That is somewhat unacceptable in 2019. And I felt Karius was able to fill that gap, not just for brain infections, but a whole host of other types of infections. So let me just go ahead and start a little bit. So we're going to use Brian's story. He is here generously to illustrate the importance of Karius in his particular medical odyssey, and that'll highlight the limits of the current infectious disease diagnostics, and then we'll show how metagenomic sequencing offers a potential solution to those limitations and pitfalls, and then I'll even have some time to go into just a few studies. So this is Brian's story. He's here on the stage, and he'll be able to tell you with more granularity and more perspective from his point of view. But around almost a year ago, just a little bit more than a year ago, he was coming back from a trip in the Dominican Republic on vacation and was otherwise healthy, and then developed signs and symptoms of pneumonia, which included fever, cough. A chest x-ray showed a really pretty severe pneumonia on the right side of his lung. He unfortunately couldn't breathe on his own, so he needed to be intubated with a breathing tube, and he had to have tubes placed to drain the fluid that was accumulating in the lung. He was put on first-line medical therapy for the antibiotic treatment, not knowing what the cause was. And of course, all the cultures were negative. The blood cultures, the pleural fluid cultures, even the rapid respiratory panel was negative. He even underwent a debulking of the lung through what's called a VATS procedure. Those surgical cultures were negative. And because he wasn't doing well, the doctors broadened his antibiotic therapy to kind of a next level to be a little bit more open-ended about all the potential causes. And still, they had no idea what was causing his infection. And that, unfortunately, is the state of art in 2019. That scenario plays itself out probably thousands of times across this country a day. And it wasn't as if he wasn't in a top medical center. He was in a really exquisite medical center that serviced the exurbs of New York City, with very dedicated physicians and top-notch modern medical care in an ICU setting, critically ill, but yet they couldn't figure out what was causing his pneumonia. So why is that the case? That's because most of our methods that are used to diagnose infections are based on 100-year-old techniques of trying to culture the organism that's causing these infections in culture in the lab. And even despite the more molecular, more modern approaches like PCR, serology, antigen testing, a significant amount of infections are still undiagnosed. And that can vary by syndrome type. So there's poor sensitivity for a lot of these diagnostics for sepsis. Only about 50% of the time when patients present with sepsis do we ever find a cause. Pneumonia is even worse. Almost 60% of the time when someone presents with pneumonia, we can't find a microbiological diagnosis. And that's a disease that affects 3 million people, Americans, every year. Okay, so why is that the case? It's because these organisms take a long time to grow, if they grow at all. Sometimes antibiotic pretreatment that was started in the outpatient confounds their ability to grow in culture. Often these infections require direct sampling of the tissue that's infected, and that often cannot be done. And even if it was done, as in Brian's case, it still was not revealing. And these more modern techniques are really geared for single organisms or small panels. They're all a la carte. You have to send them off to different labs all around the country. And then there's an information callback that's quite complex. Serology is even worse because that's the indirect evidence that you were infected. With all the immunomodulatory agents we're now using, they're completely unreliable, and they're even more specialized. And you often have to take a serology 6 weeks after the infection to get a convalescent sera. So you can imagine you can't wait 6 weeks before you start the presumptive treatment. When you cannot find a cause of an infection, mortality and morbidity goes up significantly. And so to overcome this big limitation, the Karius basically fills this gap by detecting microbial cell-free DNA that's spilled into the plasma. And this observation was made by the co-founders Mickey Curtis and Tim Blaukamp in Steve Quake's lab in around 2012 when they were studying cell-free DNA in the blood and noticed that they were seeing pathogen signals. So that was 2012. They then spun that out as a separate company in 2014 called Karius, and now we have a whole platform and product that was commercially deployed at the end of 2016. And the principle is this: you can have an infection in a localized part of the body. The pathogens in that area are dividing and spilling their DNA into the plasma. So the subtlety here is that it's circulating microbial cell-free DNA, meaning you could interrogate that from the plasma even though you have a deep-seated infection, obviating the need to actually sample the area of the body that's infected itself. Of course, when you use next-generation sequencing, because most living things, if not all living things, are made of DNA except for RNA viruses and prions, you can use one single platform as an agnostic approach to find any infectious disease, including bacteria, fungi, DNA viruses, parasites, and even archaea. And of course, this technology has already transformed medicine. It's a same type of test that's used in non-invasive prenatal diagnostics, of course, liquid biopsy for oncological purposes. And pathogen detection is just the latest in the lineage of this type of approach. What makes this even more challenging for pathogen detection, of course, is that signal-to-noise ratio is much smaller. In non-invasive prenatal diagnosis, about 10% of a maternal DNA is fetal or amniotic, so you almost can't miss at that ratio. In cancer liquid biopsy, it's 1 in 1,000. Of course, in pathogen detection, the load in the body is quite small, actually. It's, that signal-to-noise is 1 in 100,000 to 1 in a million. And one of our major innovations is enriching that signal by leveraging a unique biochemical difference between human DNA and non-human DNA to deplete out the human background and be able to detect this proverbial needle in the haystack. So even making it feasible. So how is this done? A collection of blood is done on site wherever the patient may be. DNA in that plasma sample is then extracted. The enrichment procedure is performed. The DNA is converted to Illumina-based sequencing libraries. It's loaded on the Illumina platform. The sequencer then runs for about 8 hours. That data is then curated against a database of reference strains that are curated for both clinical relevance and quality. And that itself is a complete art. An algorithm is performed that utilizes machine learning, and then we give you a report. And we report the amount of pathogen that's detected, the pathogen that's detected, along with the number of DNA fragments per microliter, called molecules per microliter. We've also run this test on normal controls to give you a reference range for context, so you know how above the normal range is the pathogen that I'm detecting. And now, of course, using that approach, we can detect a whole range of very difficult to grow bacteria, DNA viruses, and a whole range of fungi, molds, other eukaryotes, including parasites. And members of all these different kingdom affect the immunocompromised host, which are vulnerable to a very broad range of pathogens, as well as even routine infections that immunocompetent hosts get all the time. So our analytical validation was actually just recently published in Nature Microbiology, and it's actually the first peer-reviewed analytical validation of a metagenomic infectious disease test. And in it is about described roughly the synopsis of 1,000 experiments showing the decrease in bias across a range of different organisms that you have to accomplish to give you a very agnostic, open-ended test for infectious diseases. And also we include a study in sepsis where we've diagnosed sepsis nearly threefold more than conventional diagnostics. So the advantages of this approach are that it's non-invasive. Remember, we detect circulating cell-free microbial DNA. It's a liquid biopsy of sorts. The diagnostic yield, as I just alluded to, is much higher than even all conventional microbiology tests in sepsis. And then the time to diagnosis is key for infectious diseases. We give a result the next business day from sample receipt, whereas all the conventional microbiological tests take a very long time to come back. That long tail can last weeks even. And so just to give you a sense of what that pipeline looks like, of course, our technology is really built on transformative components that many of you probably have helped develop. from advances in molecular biology, rapid parallel sequencing, robust analytics, and database curation. And of course, for infectious disease, we stitch all these components in an end-to-end pipeline that is built for speed. Because unlike cancer and unlike genetics, for infectious disease, you need to know the answer today. So we again, offer a report within 1 business day of sample receipt. And each one of these components, of course, is also fine-tuned for an infectious disease application. So back to Brian's case. So here we are. And luckily, the other thing I want to mention actually here is that this is CAP accreditation and CLIA approval takes it from a research grade to a commercial grade, meaning this has undergone the robustness of analytic precision, reproducibility, and accuracy. And you need to get to those bars to be able to offer a commercial test. And in fact, this has now been offered for 2.5 years. It's affecting thousands of patients. We've done several thousand patient samples, and hundreds of institutions across the country utilize our test. And luckily, Stanford is one of those institutions. So I actually happened to have visited Dr. Asha Shah at Stanford about a week before Brian presented. She called me really in the middle of Brian's case at this point saying, you know, I know you came here a week ago, but we actually have a case right now where we're having a really difficult time diagnosing it. The patient's been on antibiotics for a week. Do you still think there's a chance we would be able to find a source? I said, he's got this amount of source control problem. There's likely a lot of pathogen there. It's probably still worth sending the test. So they sent the test, and in fact, we were able to diagnose kind of an unusual cause of pneumonia called Fusobacterium. It's an anaerobic bacteria that normally lives in the mouth, and likely an under-recognized cause of pneumonia. And based on that result, actually the antibiotics were switched to an antibiotic called metronidazole, which is, the key is that that's not often used for pneumonia, which is an interesting paradigm shift. So without that information, that would have been a very difficult call to sort of do just empirically. And after that, he had some clinical improvement and eventually was extubated. Let me just get here. So that's just one, Brian's case is just one example of pneumonia. Pneumonia is actually very common with a whole host of very diverse pathogens. And I'm just showing you clinical results in our commercial pipeline where we've diagnosed these varied causes of pneumonia, including mycoplasma, which is a cause of walking pneumonia. This is the strep that causes strep throat, also a common cause of pneumonia with human adenovirus co-infection. Here's Staph aureus. Some people know it as MRSA. That can be highly resistant to antibiotics. Here's Nocardia, kind of an unusual but also underdiagnosed form of pneumonia. And this, I could give you several pages of lists, but here's tuberculosis. Many of you will recognize. Here's endemic fungus in the Southwest, Coccidioides. Another endemic mycosis, blastomyces in the East Coast, and then in the Ohio River Valley, Histoplasma capsulatum. In fact, immunocompromised patients have an even broader range of infections that can cause pneumonia. Here's Aspergillus, opportunistic mold, Rhizopus, a very serious mold infection. Here's Pneumocystis jirovecii, a very common opportunistic infection in patients with HIV/AIDS, very common for us to diagnose. And here's Legionella, which is an atypical bacteria that can affect both immunocompromised and immunocompetent patients. Katie's slide was really important for this understanding of Legionella, because our main way we diagnose Legionella is with a urine antigen test that only picks up one serotype of the most common form. So when you look under the lamppost, all you find is what the lamppost will shine its light on. When you use an open agnostic test, no longer is Pneumophilus serogroup 1 the only thing you find. Look at this long tail: Anisa, Bosemannii, McShernii, McDadii, Brunensis, Cincinnatiensis. I've never heard of some of these things as an infectious disease doctor, right? One of these has never actually been found in a human host, Legionella brunensis. So this gives you the idea of where we are in the future, uncovering things that we just sort of assumed were a common version of these pathogens. And here's a systematic study looking at 15 consecutive cases of pneumonia just up the street at Rady. Blood cultures were only positive in one of their cases. Pleural fluid or abscess culture was only positive in one. Remember, in Brian's case, neither were positive. So even getting one is, I guess, somewhat Herculean. But in our test, we've found a plausible cause of pneumonia in 13 out of 15 patients, giving a sensitivity of nearly 90%. And most importantly, there was an antibiotic-associated change in making that diagnosis nearly 50% of the time. So imagine you're on the wrong antibiotic, and now you're now enabling the physicians to pick the right one. That's pneumonia. That's 3 million cases a year. This is a very severe type of infection, but less common, but almost as severe as you get. Other than brain infection, endocarditis, or heart valve infection is pretty important. And I'll just wrap up with another case, also from the same hospital, actually. Very typical presentation: fever, fatigue, mitral valve vegetation that you can see here. Blood cultures were negative initially, a very broad antibiotic regimen, and now the patient's physician sent the Karius test, and we find a very plausible cause of endocarditis. In fact, it's the H of the haystack group, which is a common set of organisms that cause subacute endocarditis. Now, nicely, the culture also did grow, and it's nice that you have an orthogonal confirmation of a new diagnostic. But what are we able to offer you in addition to the identification of that organism? It's the load. This is highlighting the quantitative nature of our test as a biomarker. Now, all of a sudden, when you have the quantitative nature, that becomes something you can follow as a response to treatment. It also helps you bin and batch severity of infection. These are the same, this is the same bug in the pipeline of less severe infections, and the median there is 126 of those less severe infections. Endocarditis is rip-roaring endovascular infection. It's way up here. So you're now enabled to pick the right medication and now look at the response, the delta to therapy on medical management. Now, you can imagine this being incorporated into your criteria of how well is my patient doing. Do I need to do surgery? Can I just manage this medically? If it goes up, is there embolic disease, minimal residual disease when you take the valve out? All those questions can now be answered. And in fact, this patient did get surgery, and 2 days later, you probably want to know what the test is, right? Because that's supposed to be the ultimate cure. Lo and behold, it's negative, which is pretty amazing, actually, that you now have ultimate source control. You've got a non-detectable signal. And now the other important thing is that this patient's going to get 6 weeks of antibiotics, and you can start to answer the question, do we really need 6 weeks? Could we have a study that can show that you can use this biomarker to shorten that course of therapy? Here's just another case of endocarditis in a culture negative situation, and it's picking up an organism called Bartonella. It's more common than we realize based on the use of our test, I can tell you for sure. And this would never have grown out on culture, but also that the delta of that biomarker can be now followed in a response to treatment. 1 week later, it goes down to 15,000, and then an additional 2 weeks of therapy goes down to 4,000. So you can see how useful that can be for both the patient and the clinician. Now, back to Brian's case, it's really pretty generous of him to, go through that type of infection and be willing to talk about it. So I really want to applaud him for being willing to talk about it. And I'll basically just end with the moderator and him going into his own perspective of the case, and happy to answer any additional medical questions as they come up.
Go ahead. Why don't you join us here? All right, thank you for that introduction. So, Brian, maybe we can start with your background as well. Just tell us what were you up to before you went on this trip that seems to have triggered.
Sure. Hi, I'm Brian. Nice to meet everyone. I'm a partner in a home healthcare agency, father of a 5-year-old son, and I basically just work every day and spend time with my son. So I decided to take a vacation with a couple of friends of mine, and we flew down to the Dominican Republic. And I noticed at the airport, we're rushing towards our flight, that I felt a pain in my right shoulder. And at the same time, I was carrying heavy luggage. I was carrying their bags. And we were rushing. I didn't think anything of it, so I thought it might have been just a little strain or something. So get on the plane, and as we sit down, like mostly everybody on the plane was sick. They were sneezing and coughing. And I was like, I hope I don't catch anything. I'm going on vacation, going to DR in the sun for a few days. And so get down, we land, we arrive at the airport, and go through customs, and then the airport shuttle, the shuttle comes from the resort to take us to the resort. And about 10 minutes into the ride, I had trouble breathing. And I remember the driver having the air conditioner like on full blast. and the breathing just started getting worse and worse and worse. And about half an hour later, we arrived at the resort. I didn't think anything of it. Arrived there maybe around 1 o'clock in the morning, and I said, oh, maybe I'll get something to drink or something to eat. I might feel better. That night, I couldn't sleep at all. And then the following day, my breathing started to get worse and worse. I saw a doctor on the resort, and they suggested I go to a hospital there. I refused to do so, and I said, I'll tough it out. And they said, you can only pay $1,500, get a X-ray and things of that nature. So I got an inhaler from a local pharmacy, and they told me that'll cure any lung problem you have. And I was so desperate at the time. So I said, hopefully this works. And it didn't work. And I probably used about half of that inhaler in a matter of 2 days. So my breathing started getting worse and worse. And I called my mother and I asked her to make an appointment with my primary. So when I get back, that was my plan to do so, to see my doctor. And so a couple of days later, I toughed it out. It was time to leave. And I remember just waiting for the plane at the airport. I was literally just bleeding, like breaths that shallow. And we get on the plane. I have still, breathing is getting worse. Get off the plane, land in New York, and I tried to get up, and I immediately fell over in the gateway. I couldn't walk. And they got a wheelchair for me, and I can tell you that's the quickest way to get through customs. So we go through customs, and I shouldn't say this, but in my mind, it's like, maybe in the future I'll So we get through customs, and a driver picks us up, and go from New York back into Connecticut in the car service. And I just remember my breathing I could not breathe, and I arrived home maybe like around 1 o'clock in the morning. And I called my mother, said, Mom, I think I will need to go to the hospital. The following morning, the ambulance came and picked me up. And I remember my mom following the ambulance, and they stopped the ambulance and said, you can't do that, that's against the law. So we arrived at the hospital, and then go to ER, and next thing you know, I wake up in ICU.
Jeez.
And yeah, it was a scary moment.
And at that point that you had woken up, this was after everything that has been described by Dr. Ahmed. Is that correct? Or
I think the test was sent about 7 weeks into the course while he was in the ICU.
Yep. Mm-hmm.
After his many surgeries.
Yes.
I see. Yeah. Well, I mean, was that before or after were you aware of this?
Well, at that time, when I woke up in ICU, I already had 2 surgeries, to my knowledge. I already had surgery, and I spent a matter of time in the ICU, and I remember Dr. Shaw saying that there's really nothing else we can do, so we're going to try. This company just came in about a week ago, and they're called Karius, and we're going to give it a shot. And said, are you willing to do it? My mom was present in the room. I said, sure, what else do I have to lose? I mean, and so.
Okay, going back to your comments about the Dominican Republic, you avoided medical care at that point. What was your reason? Was it financial reasons or?
No, it wasn't financial reason, and not to sound biased or anything like that, but I just thought I would receive better medical care back home in the States. So.
Yeah. I wonder what the case would have been if you had gotten medical care in the Dominican Republic.
I think I might have come back in another way, honestly. Yeah.
Yeah. Do you offer Karius in the Dominican?
Not yet.
Yeah, honestly.
Okay. So when you woke up, they described this test to you. What was your understanding, I guess, of what was going on with you at the time?
Well, I knew at the time that I was dying. I knew that I was dying, and so I was very desperate. But at the same time, I started making peace with God, and I just wanted my family to be close with me. And it's a funny story. I remember while I was in ICU, and I had the breathing machine on me, and as soon as I woke up, I started texting, and the nurse said, "You're the only person I know on life support that I can text." And I said, "I guess I'm a special breed." It's hard to talk with that in your throat. But But I was kind of desperate to reach, everyone on the outside. Just alert my friends and other people of that nature what's going on with me. So.
Yeah. Okay.
Yeah.
Okay. So, you're in this state. They ordered the test. How long did it take? Or in your perspective, I guess, how long did it take for the information to get back? What was that waiting process like?
The concept of time was kind of, elusive to me because I was heavily sedated at one point. But to my knowledge, it took no more than 2 days for the results to come back.
Okay. So the results came back.
The results came back, and
they were
Dr.
presented
Shaw,
to you, or
presented to me, and Dr. Shaw. She came in the room with good news, and she said Karius determined what type of bacteria gave you pneumonia, and now we know how to treat it. And that was very exciting news. Yeah. Very exciting.
So you just jumped on board. You sort of
life-saving news,
accepted it. Life-saving news. Yes.
Life-saving news.
And they started treatment.
They started the treatment. Yes.
So maybe you could tell us: I'm not an infectious disease person. Is this an unusual infection? How does someone end up with this type of pneumonia?
The most common cause of community-acquired pneumonia is actually Streptococcus pneumoniae. Other common causes are Group A strep, which is the one I alluded to that we showed an example of, which causes strep throat. And then Staph aureus is another major cause. Those are probably the 3 major causes. Then the walking pneumonia is mycoplasma. Then there's kind of a long tail. And what I would say is that we're under-recognizing oral flora as a cause of pneumonia. And actually this dovetails with a really beautiful study that's done by an investigator at Pittsburgh, University of Pittsburgh, named George Karius. What he has done is he's looked at the normal microbiome of the lung. Okay, normal people with no pneumonia. Guess what he finds is the #1 cause of, a component of the normal microbiome of the lung? Fusobacterium. Isn't that interesting? Now, Fusobacterium and Prevotella, the other thing we found, live in our mouth. And what's likely happening every day is we have these microaspirations every single day. Normally, our body clears it, or our immune system sops it up. But when the load is too much, or our immune system is maybe down for stress or for some other reason, all of a sudden that Fusobacterium, which normally is sopped up, has a chance to grow. And so, and a number of commercial cases in our pipeline, we've detected oral anaerobes. And the other really interesting thing about Fusobacterium is that it is an anaerobic bacteria. So it's already hard enough to culture normal bacteria. Anaerobes are another layer of difficulty. So much so that some labs, even top-notch microbiology labs in the world's best medical centers, places I've trained, cannot grow Fusobacterium in their cultures because they're so difficult to grow. So now all of a sudden you see that there's a huge blind spot there, right? There's under recognition that it causes infection, and then on top of it, we can't even grow it even if we thought of it, right? And that's where next generation sequencing and DNA fragment detection can plug that hole and fill that. And now in retrospect, based on these other studies done by these investigators like Dr. Karius at Pittsburgh, it actually makes sense. Why are we finding so much Fusobacterium infection? It's under-recognized, probably because there's this interesting, exquisite pathophysiology underpinning it with this microaspiration.
Gotcha. If there's questions from the audience, you guys can start lining up. So this is I wonder. You said you felt this pain in your shoulder. Mm-hmm. Is there anything that you could think of prior to that would have? I could understand maybe the stress of the trip or something like that leads to some sort of immunocompromisation. You're a young, healthy guy. I wonder if you could think of anything that would lead to maybe a weakened immune system, or.
I do remember aspirating. I was a late night eater, and I remember aspirating about a month and a half before, and very heavily so. A lot of contaminants went into my lungs. And so much that I had to rush to the toilet to try to vomit, but nothing really came out. So I believe that was the cause of what happened, and I think over time it just festered.
Wow. Okay.
And that fits very, well in terms of the consistency of the things that were found on the test.
Interesting. Okay, and then before I open it up, so then they started treatment, and what did that feel like?
Treatment was it was a long journey. I had to learn how to walk again, and had to even learn how to hold my head up on my own. It was tough, a very humbling experience, and I realized how fragile life is, how precious it is, and it can be taken away from you in an instant.
Yeah.
no matter how healthy you are, the smallest microorganism can destroy you, decimate you.
That's
So
incredible.
yeah, definitely.
Okay, go ahead.
Two questions. Had you had any dental work done or any dental pathology, dental pain that might have released these bacteria? The other thing is, how about antibiotic sensitivity? When you do the testing, how do you determine what it's sensitive to?
Great question. Answer the first one.
Sure. No, I didn't have any recent dental work. Not at all. I think the last was tooth cleaning about 6 months before. That's about it.
So that's a great question in terms of the antibiotic susceptibility. I think when you can't even pinpoint what bacteria is causing something, it's already a big step to identify the etiology. And for the most part, I would say, especially when they're unexpected, there are the most conservative medications you could pick for that particular organism. And that's what was done in this case. In fact, pip-tazobactam, which is an anaerobic covering antibiotic, does cover some fusobacterium, but probably not the drug of choice. And that's why the drug of choice was used for fusobacterium. It's sort of a grid match, a bug drug grid matrix that you pick the most first-line therapy. Now, of course, in each individual case, there can be exceptions, and that's why the susceptibilities are so critical. And those become important for certain organisms like Staph aureus, where you really want to know, is it MRSA or MSSA? VRE, vancomycin-resistant enterococcus, KPC, these carbapenemase Klebsiella pneumoniae. So in those situations, especially where the genotype and the phenotype of antibiotic resistance are intimately linked, we are, of course, developing those tools based on the DNA sequence to know if those signatures exist in the fragments that we detect. And we hope to offer the first two of those, which is Staph or MRSA and VRE, in the near future, hopefully in a matter of months. And then those other ones will come in line hopefully soon after that. But it's a great question. Fusobacterium, yes. Yeah. Not well studied for fusobacterium specifically, probably because we probably don't detect it as often, and it's not as high a burden as Staph aureus. But
Hi, Richard Markel, Rady School of Management. So I have a question. First of all, congratulations, and thank you for sharing your story, and also your tips for getting through customs easier. That's it. So where do you see the technology going over time, where this is a first line of diagnostics as far as cost and technology development, et cetera? Because it just seems to me like the old Petri dish is going to go by the wayside with time here, with sequencing.
Yeah, hopefully the cost will come down. And this model of doing a test 10 days into the course is obviously not ideal. In the future, you want to do it on day, in our sepsis study, it was day 2 is when the results came back. That was ordered on day 1. Results came back day 2 in the sepsis study. And you can see, ideally, you would want to push that, with speed and cost. It would hopefully be a point of care test. And then even in the future, the model is actually, what about predicting infection, right? What about predicting infection before you actually have the symptoms? So in that model where you have patients who are exquisitely vulnerable to infections, i.e. those patients at St. Jude's with cancer, they're at risk for infections all the time. So the diagnosis is made on day 0, but ideally you want to do the test in a surveillance manner. And in fact, we are doing that study where we've done interrogations on day 0 when a patient's bacteremic, and then we march back in time with biobank samples, and we see these green dots indicate that in several of these patients, although this is a little bit of a messy version of the slide, that in some of these patients you can actually see the infection day -7. So you ask about the future, that's the future. That's 10 years away probably, because who can get a test every day of their life, right? That's not going to be practical. But in 10 years when the cost goes down and you're particularly vulnerable, I'd want this test to know before I even had symptoms, do I have the inklings of that pathogen in my body so my doctors could respond to it?
Marilyn Marchione from the Associated Press. Again, thank you all for sharing your story. I wonder if you could help us understand the commercial landscape a little more. Are you the only company offering this? How many hospitals are you in? What does it cost?
Yeah, that's a great question. So this particular application of cell-free DNA of plasma, we are the only ones, to my knowledge, next-generation sequencing ID diagnostic. There are certainly ID by DNA, which is doing it on pulmonary specimens. They have a product called, I think, it sounds like Abilify, but it's not Abilify. It's like Explify, something like that. My own view of that is that the lung is already a non-sterile space. It could be a little bit more convoluting in terms of, when you, especially with a patient with cystic fibrosis, if you take their culture, they're likely to grow 4 or 5 organisms. If you use a more sensitive technique, like metagenomic sequencing, you're likely going to increase that by an order of magnitude. So how do you deal with that complexity of data? In looking at the plasma, you're kind of getting a refined signal of what potentially has made it inside the patient's body as a marker of invasivity, if you will. And then certainly Charles Chu does a really nice job for CSF samples. He's at UCSF, and his lab is supported by Abbott Viral Diagnostics. And he's one of the pioneers of this general approach. In fact, because my bailiwick was encephalitis, I've had many conversations with Charles over the years about patients that I've seen as a client, at Boston Children's. So that's kind of some of the landscape.
So again, just cost of the test,
cost,
and
yes.
how many hospitals currently?
Yeah, so the list price of the test is $2,000. But depending on the volume institution orders, that can range, in the $1,500 to $2,000 range. Yeah, and there's a separate research price as well if you were just using it for research.
Sorry, how many hospitals?
How many hospitals? Yeah, probably 100 or so hospitals have used the test. Reimbursements, mostly because we're really gearing it for acutely ill patients like Brian who are inpatients. It goes against a diagnosis-related group bundle that the hospital gets for pneumonia. So like if the hospital gets a certain amount of money for pneumonia, they have to make their own internal cost calculation. Will I save money by getting a speedier diagnosis, saving extraneous antibiotics, saving length of time in the hospital, length of time in the ICU, so we can get to the right antibiotics quicker? Unfortunately, some of the money is siloed. So the money's in the clinical micro lab, but you have to have a long-term view that there's overall cost savings for the rest of the hospital. So there's a bit of more of a bureaucratic technological architecture breakthrough that we have to, I think generally the healthcare system is broken in that way, so that's a broader problem, obviously.
Sorry, last question. Have you done or do you plan any clinical outcome studies besides just IDing a germ? What happens?
Yes, absolutely. That's sort of the phase we're entering into now. We're doing several studies in patients who are immunocompromised, who have cancer, bone marrow transplant, pneumonia in the immunocompromised host. And you're exactly right. We have to incorporate, and we are incorporating health economic metrics to show that there is cost savings, there is improvement in care, and there is improvement in quality.
We'll also hear from a young company in the space, Day Zero, in the afternoon session as well. Go ahead.
Yeah, I'm Mary Marshall. I'm with ProMed. I have a question about your use of your test, point of care and for surveillance with level 4 pathogens.
With what pathogens?
With level 4 pathogens.
Level 4 pathogens,
yeah. For example, Ebola. And
yeah.
Would you consider working, or have you considered working with the Alima cube, if you know about that? And how would you tackle asymptomatic carriers and persistent infection in protected areas of the body?
Yeah, it's a great question. So because it's a circulating cell-free DNA, you can get as sequestered as the brain. I didn't have time to show it, but we've diagnosed several brain infections. And we always talk about the blood-brain barrier. And so that's a pretty good indicator that you'll be able to diagnose infections that are kind of in these sequestered sites. For asymptomatic, we run the test on asymptomatic patients to get a sense of what our reference range is. I would say that the sweet spot of the test is really for acutely ill patients, but you are right. In the future, when we're detecting sort of a microbiome signature in the blood, there are going to be these subtle segregations of what that data means for certain disease states. But I think that's kind of a tertiary level problem it's probably more in the future than current. And And then RNA viruses we don't detect. So our enrichment procedure is really based on DNA. We are considering RNA, but that'll be a separate platform altogether. And of course, I think you're exactly right in the sense of surveillance is a critical use for the test. And in fact, last fall, we had noticed that there were several patients that all had strep pneumo, which is again very common. But because we're at the nexus of samples coming from all the country, across the country, we noticed a couple samples from San Diego and a couple samples from DC. Both had very critically ill patients, and we detected strep pneumo as a cause of culture-negative pneumonia. And lo and behold, those patients also had HUS, which is hemolytic uremic syndrome, more often associated with diarrheal disease, but certainly very well described with strep pneumo. And in fact, certain strains, epidemic strains, can cause HUS associated with strep pneumo. So can you imagine we're at this sort of nexus point, we're getting all these samples and we're the only one that knows that, okay, that this is happening. So of course we reported that to the CDC, and in fact that was a subject of a presentation at ID Week last year. So you're exactly right. You can imagine how critical this could be in picking up these signals all across the country or even all across the globe eventually that can be sort of concentrating in one place.
Are you able to detect latent TB?
Sorry, latent TB? Great question. We're likely not detecting LTBI, and I can sort of say that with some confidence. If we were detecting LTBI, we would imagine that if you just interrogated our commercial pipeline, that there'd be like sort of a 1% incidence of LTBI just as a background, and we don't see that. We only see really that signal with what we think is active TB, but I can tell you that it's a variety of forms of TB, so not just pulmonary TB, but disseminated TB, peritoneal TB, many different forms of TB. And not only TB, Mycobacteria kanzasii, Mycobacterium zenopi, Mycobacterium avium complex, Mycobacterium chimera, which was affected, the patients who were receiving heart therapy from the bypass pumps that were contaminated. So a whole range of mycobacteria that we would be able to detect.
But you're talking about active infections, right?
Yes, active infections. And even we were able to detect Mycobacterium bovis as a cause of dissemination of a therapeutic. So BCG, as you know, is a vaccine for TB, can be used for bladder cancer therapy because it's a sort of an immune recruiter. And we detected BCG-osis in a patient who had BCG for bladder cancer, an active infection. So.
Okay, thank you.
Yeah, sure.
All right. Well, we're going to touch on all these topics, surveillance, diagnosis, et cetera, of infectious disease in a lot more detail in the afternoon session. So I think we can end it here. I'd really like to thank Brian again for being willing to share a story with us. Thank you.